Between generations, we know that people who've had family members in past generations who have struggled with alcohol, it may cause problems in relationships. They may get into conflict, fights. They may get into trouble with the law. And after a time, it doesn't become pleasure. It becomes just functioning. It just becomes, I just want to feel normal. We have different substances. We talk about the reward pathway in the brain. The reward pathway is often associated with dopamine release. Smoking, let's take cannabis, for example. So if someone smokes a joint or vapes a joint, and that gives us a quick high. So you get a very quick peak and a very quick come down. Cocaine, it comes in a powder form and people, it's often either snorted or smoked. If you see cocaine and you've used it a lot, just seeing that cocaine can have a release of dopamine. You can have a bit of that pleasure already, and then using it just amplifies that feeling. Marketing plays a big role in this. Vaping is a very significant problem these days. Now nicotine, I think that's a special one because it's so potent. It gets uptaken into the brain very quickly. Teenagers will use these substances. Not all of them will. Mm-hmm. We just have to make sure they're safe, and we have to provide education. Often when a substance is being used more and more widely and more accepted, there's a perception, and we know that when there's the perception of a substance.
Hi, my name is Sarush and I'm your host. Welcome to another episode of Beyond the Scrubs on CubeCast, a new and original podcast show. Tonight's episode is very special. It's about addiction. We're going to talk about addiction, what it is, what happens in the brain, and the physiology and the science behind addiction. It's a relationship to the reward mechanism in the brain. We're going to discuss the effects of some of the more popular drugs such as cocaine, marijuana, nicotine, and vaping on the brain and the body. At the same time, we're going to talk about some of the research and the mechanisms, effective mechanisms that are available for help with recovery from drug addiction and substance abuse, and learn about some of the newest research. Tonight's guest is a very special person. He's a psychiatrist, doctor of medicine, specializing in addiction. He received his undergraduate education at McGill University. He then attended St. George's University for medical school and did his residency at the University of Toronto Medical School. He then followed up with that at Boston University with his fellowship in addiction, and he is here tonight. He is Dr. Greg Cohen. Thank you so much, Greg, for being on the show tonight. Thank you so much for being here.
It's a pleasure to be here.
To have you.
Thank you.
And so, Greg, tell us a little bit about yourself, what you do, and what your specialty is.
Yeah, so I guess it was a long journey coming into this specialty for me. I grew up in North Vancouver, and my parents were immigrants from South Africa, so they had moved to Vancouver, or they had moved originally to Toronto in the 80s, where my sister was born, and then they moved to Alberta, where they worked in a small town. They were both physicians themselves, and part of their work was part of their route to citizenship in Canada was to work in a small town. So they worked there for quite a while, and I was born in Alberta, and then we moved to North Vancouver when I was about 2 years old. And then we grew up, my sister and I grew up in this environment of medicine, so we were surrounded by stories and hearing my parents' experiences in medicine, which, we would talk about at the dinner table all the time, and it was just something that was always kind of fascinating to me. And growing up, they really instilled a sense of volunteering in us, or a sense of giving back to others. So we grew up doing volunteer work, and so that was a big part of my journey to medicine. I started working, doing volunteer work in the downtown east side when I was in high school.
That early, wow.
Yeah, and then as well when I was in university at McGill, I think this all sort of piqued my interest when I started working at a harm reduction site. So harm reduction is the term is when people use substances and they're not ready to quit, or they're using it and they may be wanting to make some changes, but they're having difficulty with it. So we want to meet people where they're at and reduce the harm associated with using it. So part of my role at the clinic was to, hand out clean or sterile needles for them to inject with, using sterile supplies for them to use for their injection, and providing education on how to inject drugs properly. Because we know people will be using substances, and if they go and use, a lot of this was as a response to the HIV and hepatitis C epidemics.
From unclean usage of needles, right?
Yeah, exactly. And so this was a response to that. And Vancouver had a really kind of special program in the early 2000s that harm reduction was one pillar of. So I found that to be fascinating. The people I met were some of the kindest and most friendly people I've ever met. And that, I think that sort of human side to it really piqued my interest. I did courses in undergrad, and I became fascinated with the brain and neuroscience, and courses in pharmacology. And I think those two just came together for me. And it was. I guess that was the route I chose from those experiences.
And part of the reason for this show is not only to talk about specific topics, right, but to also bring individuals and talk about their original story and their journey, right? Like, why did they decide to go into medicine, for example? Now, these two, bringing them together, did you always want to become a doctor growing up, or is that something that kind of shaped in your undergrad after, falling in love with the neuroscience side of it, and also your background in high school and working with these
I think it was a combination of that. I think my parents really brought a sense of both. They when we were talking at the dinner table, the feelings that came out of it were just one of just sort of problems, like, how do we solve these problems in medicine? Like, how do we do this? How do we communicate better with people? How do we treat these kind of individuals in certain ways to improve their lives? And it just, I don't know, I guess instilled a sense of curiosity in me in that way. So being surrounded by the science all the time, and when you work with people, I think that was a big part of the reason why I chose it.
Because both your parents are doctors, medical doctors. What kind of doctors are they?
So my dad's a critical care and pulmonology. So he works in the ICU and is a respirologist.
Okay.
And my mother's a pediatrician.
Okay.
Yeah. They both retired now, though. It's
so always talk of science and medicine at the dinner table, huh?
it was. We were surrounded by it.
It just made sense for you to continue the path, right?
Yeah, exactly. Yeah.
Did they ever influence you into, wanting you to become a medical doctor, but at the same time influence your decision to go into psychiatry?
Yeah, I don't think so. I think they gave me a realistic appraisal, I guess, of what medicine is like. So they didn't sugarcoat it. When I was young, I'd see, my dad would prop me up on the bathroom counter and he'd shave in the morning, and I'd kind of do the same thing when I was 3 years old. And, that I saw how difficult it could be, getting up really, really early in the morning, getting home late, the difficulties in scheduling, right? And sometimes they were not at home all the time. And they
especially if both of them are, in that profession, right? It's very difficult. Yeah,
it is. And they did their best. And they did a great job. So I'm I think indebted to them in how they managed such a difficult circumstance, especially moving from a foreign country and adjusting to a new place. There were some health problems in our family when we were younger as well, and they navigated that, as best as they could. And I think part of that, like that intersection with the healthcare system, also sort of drove me to want to go into the specialty.
That's awesome.
Yeah.
That's fantastic. So tell me a little bit about that journey and the challenges that you faced after undergrad in Montreal, deciding to go to medical school, and then finishing medical school and then deciding residency, right? So what was your feeling? How was that process like for you?
Probably one of the hardest things I've ever done. Yeah, it's, undergrad is a time for exploring your interests, you're still developing your identity, you're making connections and networking, and, it's a fun time in one's life while having to balance there's a lot of unknowns in terms of, your trajectory. If you want to go into medicine, a lot of people have that idea.
Yeah.
And often there's a kind of a preset course you can take in undergrad. There are prerequisites everyone has to take. And so my thought was, I have to do this. I have to do these prerequisites. And it was a bit of pressure that I put on myself. And I struggled with that. I did. I remember the first 2 years were really difficult. And I needed some extra support during that time. Now, part of that I think I learned through that was that I don't have to go in one set path. I don't have to take these courses to do medicine, right? So I switched my my major and chose things I really wanted to do because not because I felt pressure, but because I wanted to and I was interested in this. And with extra supports in place for me, I was able to get into medical school, and I was really, I feel privileged to have been able to access those supports. A lot of people don't. And I've been able to I was able to access them throughout medical school and later on as well. So, I think it was a challenge in terms of, jumping through those hoops. And then in residency is, medical school, you have a sort of 2-year period of academics where you're doing a lot of book work. You're studying all the time. If you're able to sit down and study and retain and, do the exams, great. But then you go into your rotations and there's
more difficult.
More difficult. You're still learning, you're still reading, but there's you're not sleeping well. You're doing different rotations. You're taking in a ton of new information. There's a lot of sacrifice that you have to make. And it comes out on the other end where you decide, is this, what is the specialty that I want to go into now? So you have to then decide based on sometimes 6 weeks of a rotation.
Yeah,
right?
what you want to do, where your career is going to lie, right?
What you want to do for the rest of your life.
So how did you make that decision? Because I know that's, weeks and months and years of in planning and thinking, and you say you have to make a decision very quickly, right?
Yeah, for sure.
So how did you decide that, I'm going to pursue psychiatry?
Yeah, I think part of it was a bit of naivety on my part. Reading books is not the real world, and reading about pharmacology and, that stuff fascinated me. And when I did my rotation, I still really loved it, but I saw how difficult it was. I saw that it's, it's a very challenging specialty for many reasons. And at the same time, very rewarding. So I had chosen psychiatry. It's, it's a specialty people don't often choose to go into.
Exactly, because my last guest actually said that it's declining people, medical school going into the residency of psychiatry. So.
And I think, we can talk about how it's such a rewarding specialty. My intention was always to do some general psychiatry, but also addiction psychiatry. That was always sort of my goal. And having done rotations in medical school in addiction medicine and addiction psychiatry, that's solidified it for me. I think the challenge for me, the next challenge was residency. That's where you're, that level of responsibility is a bit higher. You are being evaluated constantly, but you're making a lot of the decisions yourself now. So you go from being, there's oversight from a resident and you're attending or the
clinician,
exactly, to being on your own and sort of you have to teach and you're being observed, but you're making a lot of those decisions right away. So I found that to be quite a challenge and a transition. And again, I found one of the most difficult things for me was being on call, because you're on call every fourth night usually. So you come in the morning, you stay till the next day, so you're up for 24 hours straight. I'm someone who likes my sleep, so I found that to be really challenging.
Yeah, that is challenging. I think that's not something that people really do know or recognize, that during residency you have these sleepless nights, right?
Yeah, and I think there's a mentality of pushing through a lot of the time in medicine, of what we call presenteeism, where you show up to work, you may not be feeling well, but you do it because you feel you're committed to it and you want to do this, and you want to support your colleagues as well. Right?
Absolutely. And so during residency, you decided it was a mix of just general psychiatry and then also addiction psychiatry as well, and that's what you're doing right now, right?
Yeah. So we do. It's a 5-year residency. The first year is what's called a rotating internship, where you do 1 month of you do general medicine, neurology, emergency medicine. I even remember in my emergency medicine rotation, we were called to the trauma bay to help with someone who was in a severe car accident, and everyone is sort of doing their thing, they're focused, and one of the general surgery residents said to me, "Come here and help me. Which specialty are you?" And I said, "Psychiatry." And he just looked at me and said, "Did you say physiatry, right?" "No, psychiatry." And he just side glanced me and kept doing it. He's like, yeah. He's like, "Okay, yeah, you can watch." So yeah, that's that was the year. You kind of rotate through different rotations. You get to meet different different people, your future colleagues that you're going to be working with. And then second year is sort of the core psychiatry. You do inpatient general, outpatient general, where you're working with people with severe and persistent mental illnesses that range anywhere from people who suffer from diseases like schizophrenia, bipolar disorder, major depressive disorder, trauma. So you get we had a variety of different experiences practicing sort of the bread and butter of psychiatry then, and then you specialize a bit more in third and fourth year. You do a bit more older adult medicine, and then younger adult, children, adolescent, and that's sort of when I started doing more electives in addiction medicine, and just I knew that was for me.
That was for you, right?
Yeah.
And then you did your fellowship in Boston, right?
Yes.
Okay. And how long was that?
That was a year.
Just a year. Okay. So you went and then you came back and you were practicing for you. So you're doing a mix of both of these, general psychiatry right now and addiction medicine. Well, fantastic. That's a very inspiring, interesting journey. And I appreciate the fact that you said that you had all these struggles from your undergrad and also through, medical school and residency, but you use your resources and tools to be able to pull through, and now you're here. Right?
I think it's important to talk about, because it's not talked about a lot, and there's still a stigma within the healthcare profession of anyone who struggles to not tell anyone or to keep it in, right? But I think it's important we do have these conversations.
Yeah, and I think sometimes they just assume that you have to power through it and you can do it, and you're smart, you're dedicated, but everyone can have struggles, right? And doesn't matter what you do, right?
For sure.
So, Craig, I want to get into a little bit of specifics about addiction. And, first of all, if you can describe to us what is addiction and why does it happen? How does it happen? What happens in the body that you get addicted?
Yeah. So addiction is, scientifically known as a condition that someone becomes dependent on a substance, or they consume a substance, and over time it serves a need for them somehow. So I often see it as someone meeting an unfulfilled need in their life, right? We talk about sort of the biological, the psychological, and the social spectrum of different aspects of people's healthcare in general. And so someone might be using a substance just recreationally because they have an illness, right? People who maybe struggle with bipolar disorder and they're in a depressive phase, alcohol can often make them feel better, right? Or an opioid might make them feel better, right? Nothing makes them feel better. Often the treatments they can be effective, but sometimes people can struggle with depression where the treatments aren't as effective.
And by treatments, you mean medicinal treatments and maybe psychotherapy?
Exactly. So a combination of medication, psychotherapy, social supports that are in place, what we call psychosocial rehabilitation, that kind of spectrum. And someone might they might have a genetic predisposition to it. So they may have had a family member who struggled with alcohol in their past. So that predisposes them to develop one as well.
Oh, so there is a good genetic component related to addiction.
Oh, yeah. Yeah. So we know, for example, with alcohol, between generations, we know that people who've had family members in past generations who've struggled with alcohol, their opioid receptor in their brain is not working as well. So we know that their ability to process pleasure is different. And when people drink and they have that past history, there's a sort of more of a liking of the alcohol. It sort of gives them more relief. So there's pretty good research, biological research actually showing that.
Okay. And does that happen if the parents, for example, if the mother has been drinking when the baby inside the womb, or how does that develop?
How does it develop later on, or the addiction?
Yeah.
So there's many different ways. So kind of coming back to your definition. So it's a condition where someone becomes dependent on a substance, and they use it more and more to achieve a certain effect for them. And then I think it's also important to clarify dependence on something versus an addiction, right? So physical dependence is when someone takes something, and it doesn't even have to be a drug. It could be a medication, right? So if someone takes a medication for blood pressure, your body reduces its blood pressure when you take the medication. And if you take it long enough, your body depends on it, right, for that. If you stop it abruptly, your blood pressure could go up, right? That's a definition of dependence, right? So your body kind of depends on it. Otherwise, it goes through a state of rebound or going back to its original state. And then it takes some time for it to get back to that original state. Physical dependence is a part of that, but it's not it's not the only part, and it doesn't have to be someone doesn't necessarily have to be dependent on a substance. So it's really when it causes problems in someone's life. So they use it more frequently, and in those periods of using, it may cause problems in relationships. They may get into conflict, fights. They may get into trouble with the law. They have difficulty controlling their use. So people might use more. They might use on, say, a given day, and then they just escalate that. After that first drink, they can't stop themselves, and they keep going and going and going. And that leads to a lot of negative consequences in someone's life. And then craving. So craving the substance when they're not using it. Over time, people have strong urges, and that makes it difficult to stop using. And then we look at the sort of physiology of it after someone does become dependent on it, they go through a state of withdrawal. So it's sort of the opposite state of what the substance does for them. So they may become depressed, dysphoric, restless, agitated, and it's a horrible feeling, right? And so the natural thing to do is to stop that feeling by using again, and it's a cycle, and it creates that cycle. So
using even more to try to see if you can get back to that state of, I guess, pleasure, right?
And after a time, it doesn't become pleasure. It becomes just functioning. It just becomes, I just want to feel normal, or I just want to feel okay.
Because you've had that, okay, I see what you're saying.
So your body becomes tolerant to it. You need more and more to get that same effect. And at a certain point, it's not pleasurable anymore. It becomes something to help someone function or feel okay.
Function normally, right? Well, quote unquote, right?
Yeah.
So can you tell us a little bit of the physiology of what happens inside the brain with substance abuse and addiction, so that we have an understanding of all these neurotransmitters and, the reward mechanism happening inside the brain. I think it's really fascinating. I find it fascinating, but I think the audience would love to hear a little bit of the science.
Yeah, it's a complex topic. I mean, I think we don't know everything yet.
Yeah.
So we have different substances, right? And, we talk about the reward pathway in the brain, right? So the reward pathway is often associated with dopamine release, right?
And dopamine is one of the neurotransmitters, right?
Yeah. So dopamine is a neurotransmitter in our brain, which what happens is when that's released, it binds to certain receptors, which is like a lock, and the dopamine unlocks that receptor and causes neurons to fire. So what that does is that those neurons are the pleasure neurons, and they attach to parts of our brain that are associated with judgment or planning, and so we, our inhibitions are maybe lost a little bit. We feel relaxed, we feel calm, right? Other substances can do the opposite. They may make us feel euphoric or good, but they're stimulants, so they make us feel high. Like they give us energy. They kind of make us very hyperactive, right? So different substances do different things. Now, often what's important is the way a substance is taken.
Okay.
So often developing an addiction is associated, often with a predisposition, and there's other background factors that might increase the risk of someone developing a substance use disorder. And then the mode of use. So, for example, smoking. Let's take cannabis, for example. So if someone smokes a joint or vapes a joint, you're inhaling that right into your lungs, and that goes directly to your brain, right? So it's a very fast uptake. Or even nicotine, we can say, right? So nicotine, we inhale through a vape. It goes directly to our brain very rapidly, and that gives us a quick high. So you get a very quick peak and a very quick come down. So you get the high and then the come down very quickly. And so people feel that burst of euphoria and feeling well, but it comes down quickly. And then they do it more and more because that way of using it by smoking it gives you that rapid up and down, right? If you're using, say, chewing tobacco, you get sort of a slower high and then a slower low. And so that
goes through the digestive system, right? So
yeah, generally, I mean, another example would be like gum, like nicotine gum. So that's often a way to treat cigarette addiction, because you get a very slow uptick of nicotine and then a very slow down. So there's much less risk of becoming dependent on that. And in fact, it's a way for people to kind of normalize their nicotine receptors in the brain by making it a very slow process and then weaning themselves off of it.
So the faster it gets to your brain, the higher chance of addiction.
Generally speaking.
Speaking, yeah.
Yeah.
Okay. So, say for example, someone takes a drug. Let's use cocaine, for example. Can you use that to give us an example of exactly what happens in the brain using this physiology that you just described?
For sure. Yeah. So cocaine, it comes in a powder form, and people will, it's often either snorted or smoked. Those are the two most common ways of using it. When it goes to the brain, so it goes through blood vessels, through something called the blood-brain barrier, and that's what protects the blood vessels from your brain tissue, right? It's a way of filtering out toxins, but cocaine can get through. And what it does is in a certain part of the brain called the mesolimbic dopamine region, that's where we feel pleasure. And there's neurons that it binds to on the dopamine receptor that it activates. And it's a complex pathway. So it in that area, it activates neurons that go to our frontal cortex. And again, like I had mentioned, it kind of affects our judgment, our planning, our ability to organize ourselves, our motor behavior, so like how we move, right? And our internal emotional state, right? So it's the dopamine receptor often that is associated with that feeling high. We're actually learning more. It's not only the feeling, dopamine isn't associated necessarily with the feeling of high, but the anticipation of reward. So if you see cocaine and you've used it a lot, just seeing that cocaine can have a release of dopamine. You can have a bit of that pleasure already, and then using it just amplifies that feeling.
Amplifies it, right?
Yeah.
Okay.
Yeah.
So you said some of the drugs can give you that sense of high, but some of them can also really, or I guess in your actions you become very excited, right? But some can also bring you down. How does the physiology of that work?
Yeah, it's a good question, and it's quite complex in terms of how those receptors work. Different receptors have different functions in the brain, right? And so some of them are like the dopamine receptor. If there's too much dopamine, then that can put us essentially into overdrive, our brains into overdrive. We start to kind of have difficulty in filtering out what in the world, sort of what is real and what's not. We get our senses are flooded, our heart races, so it causes a lot of adrenaline release. Our hearts race. We start breathing faster, so it's like getting a pumped full of adrenaline in a way. And so those are certain receptors that are associated with that drug. Alcohol, for example, is considered a depressant, and it acts on certain receptors, other receptors in the brain called GABA receptors, and those are more associated with calming our system down. So we have less adrenaline released. It sort of slows our heart rate down, our breathing down. It calms us down. It makes us feel less anxious. So people generally who struggle with anxiety, who may have an anxiety disorder or a history of trauma, often it's a way for them to cope with that trauma or that anxiety.
It relaxes the brain a little bit, right?
And so essentially people who struggle, because we know people who have who struggle with severe mental illness, often using a substance is filling that unmet need of my anxiety is not being treated, my trauma is not being treated, and it's a way to cope with that. It's a way to almost seek safety from those terrible experiences.
Okay. What does the science say, now that you mentioned that, in terms of mental health or depression or anxiety, stress? What does the science say about the correlation of that and substance abuse, addiction, and
between mental health and substance use? So there's a very strong correlation, right? Again, it's quite a complex topic, because every condition is different. Every condition causes different people to have different experiences, and everyone has their own background. Everyone's an individual that brings their own history forward, right? And they interact with that substance in a very individual way. So we know that certain illnesses, like schizophrenia, for example, there's a high rate of tobacco use in schizophrenia. Upwards of 70 to 80%.
Oh, wow.
It's very high. One of the thoughts is that people find it with schizophrenia, people can have symptoms that affect their motivation. It affects their sort of ability to take initiative, to go and do things. It can really affect their ability to carry out their daily activities. And tobacco is thought to sort of to be a stimulant in a way for them. It sort of activates them. There's also a bit of a function where it can help them think more clearly. It improves people's cognition in a way. And so people find that it brings them relief. People with schizophrenia often find that it can bring them relief in a way, and help motivate them. So it's very individual based on the substance. I mean, some people who have trauma, right? People who have trauma, often their nervous system is in overdrive, so they're in kind of fight or flight mode, right? So something that is a trigger from the past, their heart races, they become sweaty, they become anxious. Sometimes there's a very high rate of alcohol use in people with PTSD, right? And part of that is to kind of calm that nervous system down.
Relax the brain a little bit.
Yeah, so it's sort of, we see it as a kind of, it's something that is adaptive initially. It sort of helps them calm down initially, but then very quickly becomes maladaptive, and it affects other parts of their life.
Okay. So speaking of kind of like the behavior component and the psychosocial component, you always hear that sentence, I have an addictive personality, or I don't have an addictive personality. What does that mean? Like, what is there any truth to that necessarily, that some people might have more addictive personalities than others?
Yeah.
Is there science behind it?
I don't know if I would put that, because addiction is something that is sort of external, right? The substance is external, and so it can't be something internal necessarily. Now, everyone has certain personality traits or behavioral traits, right, that predispose them to potentially using. So someone who maybe struggles with impulse control. So someone may have some symptoms of attention deficit hyperactivity disorder, right? Where we know that that's a neurodevelopmental disorder where there's a deficiency of dopamine. And that causes people to feel restless. They seek out reward. They're very sort of they very much desire having some type of reward, and so they're at higher risk than the general population of developing a substance use issue, because it brings them some calm. So people often use stimulants or alcohol because it just calms their brain down in a way. So it's more about sort of what trait does someone have that could put them at risk. If they struggle with impulse control, and they use substances impulsively, then that could put them at risk for developing something down the road. Okay.
So it's more about, it's very multifactorial, as you're saying. There's some predispositions, and then the psychosocial factor, and whether what you've gone through. A lot of these things make a difference between whether you're going to use it or not use it, right? And what effect is it going to have on your brain, whether you become addicted to it or not, right?
Because you could live completely isolated from substances and never access them, but struggle with ADHD, right? And so you may never know what a substance is, right? So it's something that's more external, and people who struggle, who sort of identify with that addictive personality, often it's a combination. It's that coming together of genetic predisposition, psychological factors related to their upbringing, and the environment that they're in, and often the two go together.
Absolutely. I have a couple of questions about some specific drugs that are super common, and there's always these conversations around events, gatherings, and people that use them, or friends, where they claim that it's not necessarily too addictive, or I don't have an addictive behavior, and I just do it because it's recreational for me. And I just want to take your take on the effects of these and how addictive some of these drugs can be. So one, for example, that's become so common with teenagers nowadays is vaping. And they're so readily available. You can buy them off Amazon now. And I know teenagers, they use them daily. And how addictive are these? How bad are these for you? And should they be? Should there be like some sort of a ban on them or not? Until at least a certain age, right?
I mean, I mean, this predates me, but if, back in I think it was the 60s and 70s, when the tobacco companies were advertising, they were strong in their sort of advertising of tobacco, right? Yeah. And they really were ahead of the science at the time. And people weren't aware of how problematic this, tobacco or nicotine was. So marketing plays a big role in this. And really, I think our society has had difficulty in sort of finding a balance between our freedoms and our ability to choose what we want to do, but also regulating it so that we can protect the population, right? So there needs to be a balance of that. In children and teenagers who are, their brains are developing, they're learning, they're experimenting with everything in their life. They often don't have an awareness of how this can affect them, right? Vaping is a very significant problem these days. With the advent of certain companies, I won't name them, but they marketed heavily, and there weren't any regulations not to do this for teenagers, if you can believe that. So young kids could go, they weren't allowed to buy cigarettes, but they could buy a cartridge of nicotine that probably has, 10 times more nicotine than a pack of cigarettes in it.
And they could just readily use it.
And they could. And, it's, I think it's one thing to say, I think we live in a culture as well of being fearful of this, of substance use. So the statistics, they show, right? So 10%, so if 100 people use a substance on a regular basis, then 10 of those people will start to develop a problem with it later on in their
10%
lifetime.
statistics.
So 10% of people will develop a substance use problem if they use a substance. So not, people use recreationally and they use it in a safe way, and not everyone becomes dependent or uses in a problematic way. Now, nicotine, I think that's a special one because it's so potent. It gets uptaken into the brain very quickly. Teenagers, again, they're learning impulse control, they're learning emotional regulation, and this really can stunt them in that way.
Yeah, so it can be quite addictive.
It can be very,
yeah. And so hopefully maybe some regulation comes to effect to help with.
I think it has. I think there were these pouches that were being sold over the counter recently in the news. They were like snooze. I can't remember the name, but you basically put it under your lip, and it releases nicotine slowly into your blood, kind of similar to the gum we were talking about. But again, kids can buy this over the counter. It's
oh man, it's interesting.
yeah.
A bit scary, in my opinion.
I think so, and I think it is. But I also think we have to understand and look back and see that when we were teenagers, we were probably experimenting to an extent, and teenagers will use these substances. Not all of them will. We just have to make sure they're safe, and we have to provide education, right? We can't scare them.
Education is important around it. Yeah, it's
very important. And how do you do this safely? Most important is, do you have someone safe that you are with if you are going to use a substance? We often educate with parents, like, to have those conversations with their children, right? To be aware that these are the dangers of using substances. Make sure if you are going to use anything like marijuana or tobacco, like you have someone there who can be a safe person, right? Or alcohol even, right? Because it is common, right? Teens use substances. Cannabis is widely used now in youth. And cannabis and alcohol are more of the kind of psychoactive substances, right? That can impair them. So harm reduction in youth is crucial.
Crucial, yeah.
Yeah.
Comes back to, I guess, education, and then a little bit of changes in the cultural perception of these things and how we even look at it, right?
Absolutely.
So another drug that has become quite common, especially in parties, is cocaine. And some of the common language or sayings around this drug specifically is that, it's the, I don't know, like the things I've heard, cleanest drug, or, it just gives me a quick high, and, I've had many drinks, I have a little bit of that, and, it makes me feel good, or makes me feel powerful, and, I don't get addicted to it, or I feel strong, good, and, I could go off of it anytime I want to. What does the science say behind that? Is that true? Is that not true?
So in terms of that it's not addictive, or that it's...
Well, there's a lot of claims that it's not as addictive as other drugs, and that it just gives me a sense of power and control, and then, I could go off of it anytime I want to. And it's used highly recreationally right now, and it's highly increasing, and you see it a lot more now. So
yeah. I think there often when a substance is being used more and more widely and more accepted, there's a perception, and we know that when there's the perception of a substance, of the risk of the substance starts decreasing, meaning that people start thinking it's less risky to use, then consumption goes up and use goes up, right? It's there are epidemiological studies on this, right? And so I think the awareness of the dangers of it go down as well. So I don't know that it's necessarily more an issue of more or less addictive. It's more of like the perception of risk when you are using.
I think that has changed for sure because it's become so readily available and just, on the party scene especially, right? And especially new generation. So
it is. And I think one of the other, my biggest concern with this is the toxic drug supply right now is it's so volatile that when people go out and they buy cocaine, they can have an overdose. They don't know what's in it, right?
Oh, from other
substances being in it.
It's kind of like fentanyl and things like that could be inside, right?
Yeah.
Or even not even knowing how much to use, and they use too much and they could get an overdose from cocaine itself.
Absolutely.
Yeah. I think there's been a lot of stories actually in the news in our own city lately of these overdoses of toxic mixed drugs, right?
Absolutely. Yeah.
So it's becoming very common these days.
Yeah.
And so I think the next one that has become probably the most commonly used is cannabis, marijuana.
Yeah.
And I think the number one sentence that a lot of users of marijuana that say or use or claim is that this is non-addictive at all, and it's got medicinal purposes, and that it actually has a lot of benefits to you, so everyone should use it. So we hear a lot of that. So can you tell us the science behind that? Is that true? What your thoughts are?
Again,
and also another question is that they usually, on the other side, they say, it's a gateway drug, right? So what is the truth?
So the science on that is mixed. There is some evidence to that about the gateway effect. And again, I think a lot of it depends on predispositions, genetic predispositions, personality predispositions. Is someone more prone to impulsively using substances? And who, what is their social network? How do they access these substances? Because it can develop into that. Again, I think marketing in our culture is ahead of the science on cannabis. There's a lot of misinformation about cannabis and its effect and its positive effect. And our regulatory, when cannabis was first legalized, our federal government, they have certain mechanisms in place to protect youth, and there wasn't anything to sort of regulate advertising in certain ways, or the way you could talk about cannabis or promote it, right? There are certain restrictions on advertising, like on billboards and in shops, and you have to be very, it's quite regulated in that way. But people go on the internet. It's, there's, I would guess, hundreds of thousands of sites out there, purporting that cannabis can cure this, can cure that.
Hundreds,
clinics
thousands,
you can go to. I think, again, it's one of those things where we know where the perception of risk, because it's been legalized, the perception of risk has come down, so the use has gone up. And that's especially true in young people where they see that risk has come down because it's so widely used. And I believe it's overtaken alcohol in terms of kind of commonality of use. Of use,
yeah. So is it addictive?
You can develop problems with it, yes. So you can develop, a substance use disorder, or cannabis use disorders is the term we use. So it's a little bit, it's a little bit more insidious in that people, when they use it, they become intoxicated from it, right? And they do develop a high from it. The effects from it might not be as apparent as, say, developing a problem from alcohol, where if someone is very intoxicated, they could get into, they could be injured pretty quickly, right? I mean, cannabis you can as well if you, if you get behind the wheel when you use it.
Of course.
But again, there's this perception that, people who use cannabis kind of, they're not as active, so they might not go out and get into an accident or get into trouble in that way. But people do. A lot of people use cannabis day to day. They function. It's a bit more insidious in that the problems that develop happen slowly over time, compared to, say, some of the other substances. And we often see people coming into our psychiatric practices as well who use cannabis to help them with their depression. Right? They've tried different treatments. They perceive nothing has worked for them, yet they're more and more anxious and more depressed despite continuing to use it. And a lot of this, I think, my sort of, doing a lot of reading and sort of discussions with patients and understanding their stories is that perception, because that perception of risk is low now or lower, they don't believe it contributes to their problems necessarily. And some do. Some see it as a problem. And I think, again, the marketing, the advertising, the legalization aspect of it, really, I think, put into the public sort of psyche that this is a safe thing.
This is more okay. Or it's like the perception that's not as bad. Okay.
Yeah. And people can really struggle with it, right? I mean, we know the potency of cannabis compared to 20 years ago. It used to be 1 to 5%. It's up to 20, 30% these days. So it's quadrupled or even more sometimes. So there is a risk. People can become dependent. There's a withdrawal syndrome. So when you use for a long time, sometimes we see people coming into hospital and they're agitated, they're irritable, they're anxious, they're sweating, they're vomiting, they're just very unwell, and no one knows what's going on until someone asks them, do you use any substances? And they talk about their cannabis use, and eventually they learn that is part of it. So we know that sort of that tolerance to it and that withdrawal is part of that kind of spectrum of developing a use disorder. Yeah.
So very similar to other types of drugs and dependencies, but maybe a little bit more slower and longer, that some of the effects might not be seen right away.
Yeah. I would say the one of the bigger risks that we worry about is again, young people's brains are developing, so it can definitely affect their cognitive development. We know that the longer they use, the higher potency they use, the more it can affect their ability to their problem-solving skills, their judgment, again, their impulse control, all those aspects of cognition that are important. And especially young people who are at risk of developing a psychosis. So psychosis, which is an illness where there's, people can develop beliefs that are, paranoid, or they believe people are following them, or where there's a bit of a break from reality. They can hear voices. Their thoughts can become very jumbled and confused. They don't know what's real and what's not. So young people are very at risk of developing this, especially if they have a family member who has an illness like that.
Yeah.
And that's one of the things we do see in our healthcare system is young people who come into the emergency departments in a state of psychosis, unwell, and often the cannabis is sort of the trigger that's unmasked it, and can lead to further problems later on.
Well, that's I think a very good answer in terms of the uses of these, and I think you touched base on how much more potent these can be on kids, as their brains are developing, has a lot more wider effect long term. Now, speaking of the clinical side of things, you touched based on how do you treat addiction, and as a psychiatrist specializing in addiction, what do you do? Like, how do you tackle this problem?
Yeah, I mean, I think as doctors, our roles are to work with individuals and work within a healthcare system and advocate for changes, right? So addiction is a very complex condition. It involves not only an individual's state of using substances, but it involves, I guess, it's really understanding who's in front of you, who is the person in front of you, what are their circumstances, what led them, like hearing their life story, what led them to coming in to see you, what was that trajectory up until using substances. It's so important to understand their life history so that you can develop an understanding and work with them on some of those issues, because you may discover that they have an underlying trauma that hasn't been treated, or it's just been sort of lingering and it hasn't been picked up. And that's what's driving their substance use, right? There are so many reasons. It's really about finding that unmet need as to why someone uses substances.
The reason behind it that it started in the first place anyways, and has that dependency on it, right?
Yeah. And now it's a bit of, it can be a bit of a chicken or egg issue where people's social circumstances can also be involved, right? So people historically who've been marginalized, Indigenous populations, people of color, who've been discriminated against in our healthcare system are at higher risk of this as well. And often, they don't have the access to the healthcare that they need. They don't, they've been stigmatized in our healthcare system, which leads to potentially worse outcomes for them. People who don't have housing, right? We know that people experiencing homelessness, either most of the or not most of the time, but a large proportion of people do have mental illness, untreated mental illness, untreated substance use. And that's a big contributing factor to perpetuating and continuing of their substance use and their mental illness, right? So it becomes a cycle. And if some of the core issues in our society are not addressed, so we need, affordable housing.
That's right.
Housing should be a right for everyone, right? And that way they can have a safe place with supports in place so they can access treatment if they choose, right? And some people choose not to access treatment, and that's their decision. We have to meet them where they're at, but we need to provide a scaffold for the most vulnerable people in our society so that they have the ability to choose if they want to or not, right?
So a lot of different factors involved, and you have to make sure you tackle everything from the reason that led to it, but also provide a safe environment and, the social side, the environmental side, to make sure that there's good support network.
And then in terms of, in terms of other treatments, so, we use medications as well.
That was my next question, actually. Yeah.
So there's the sort of the biological piece as well. So depending on the substance, we often have medications that can be very helpful in stabilizing someone's substance use. So if someone is using fentanyl, there are evidence-based treatments that have been around for decades that can really help people stabilize their use. Some of those medications do have side effects, and there's perceptions about the safety of them, but they've been studied for decades and they've been very effective. One of the issues now is that in the last, maybe almost 10 years now since fentanyl has arrived, and is a much more potent, much stronger substance, it's become more challenging to stabilize people on these medications because the medications often have a what we call a titration period, which means a period of sometimes weeks to get them to a place on the medication where they're stable enough. So it can take some time, and because the drug supply is so strong and toxic and potent, people sometimes don't come back to treatment because they're not feeling stable enough. And so we also need, we're in addiction medicine, we're always learning new ways, new techniques to start people on these medications to get them stabilized much faster. We need more facilities where people can go and have a safe place to start the medication, right? Because sometimes their situation is chaotic and they're not able to stabilize in the community. So it's really about kind of looking for supports in the community, a place where they can stay, where we can treat them and get them stabilized on a medication such that they can be able to reduce their use if that's their goal, and then come up with sort of plans for moving forward, looking at finding a job, looking at finding housing, right? Starting a family or re-engaging with their own families, right? So medications can be really, really helpful as a tool.
So it's a combination of like the biological, medicinal side and the psychotherapy, and changing some of their environmental and social settings. But can you maybe give us one example of a specific? So, for example, someone comes into your office with an opioid addiction, right? Can you talk about the steps you would go through of a case or an example, so people have a really exact idea of what this treatment is exactly?
Yeah. So, if we see people who are using fentanyl, and they come into our clinic, and the nurse will see them and assess them first and get a bit of a background. So they'll do a bit of a history, take a bit of a history from them. So ask about, why are you coming in today? What is your goal, right? What is your motivation? They ask about sort of the substance they're using, the amount they're using. Has it led to any overdoses, right? We always ask about sort of safety and harm reduction related questions. how does it affect your life? Like, how has it affected you? What problems has it caused? What other problems are leading to your substance use, as we kind of talked about before? And then we ask about their medical history, their psychiatric history. We ask about their social history, so we get a full history, and then we discuss with them the different options. So if someone is using fentanyl and they're tolerant, meaning they need to use a lot so that they don't go into withdrawal, we choose a medication. So one of the options we use is a medication called methadone. It's an old medication. It's been around for decades, and it's been well studied, and it is an opioid medication. However, it has certain properties that allow you to reduce your reliance on fentanyl, so that you're not having cravings when you're on methadone. It allows you to stabilize in terms of withdrawal, so you can go days. Initially when you start, it might be like a few hours. As your dose of methadone goes up, it might be a few days that you can go without using fentanyl, and then when you get to a stable dose, it kind of blocks the fentanyl from working. And so people find that it can last anywhere up to 72 hours, one dose for some people. And so it stabilizes them in that way, so that they don't have those cravings, that strong urge to go and use, that discomfort that they feel. So they're not in that cycle of using and going into withdrawal. And so we often get to a place with people on a dose of methadone, and that's when they're able to engage in therapy and learn about why they use substances. Learn
Psychotherapy
Exactly. Yeah. So it's a tool. It's not the only treatment. So we really try and engage them in a kind of multimodal way of treatment. And we have a whole team as well. We have in our system social workers who provide therapy. We have occupational therapists. Nurses provide medication to the patients. So it's really important to have a multidisciplinary team acting to help patients in their recovery. Yeah.
And so, in your expertise in terms of the effect or the success of these treatments, do you find that the combination of, obviously, it's very multifactorial. It's not just the medication and the psychotherapy and providing, but it's also a choice for the person as well, right?
Yeah.
Are you finding, or do you find that the trends in the science and the literature is showing that these efforts are becoming more and more effective in terms of dealing with addiction and helping people and getting them to recover from it?
Yeah, I think it's the medications have been well studied. Their evidence has been well established already. We're just finding new and novel ways to get people started on the medication fast enough to stabilize them, because a lot of them do take time to get to a stable dose, because they have risks themselves. And so part of what we're trying to do in the addiction medicine world is finding new and novel ways so that people can start on the medication to reach their goal. So some people might come in and they say, I don't want to quit using fentanyl. I want to continue using, but I don't want to have an overdose. I don't want to die of an overdose, right? And so we need to work with them where they're at, listen to them, and provide the treatment such that we can keep them alive, right? Such that they're meeting their goal, meeting them where they're at with it. And then continuing to engage them and see what they want out of their treatment and out of their life. They may want to use a little bit of fentanyl here and there in a safe way, have methadone as sort of a backbone to prevent overdose and stabilize so that they can function, right? And so that's an important part of understanding, or of their recovery, is understanding what they want out of their treatment and really trying to develop these new ways so that we can rapidly stabilize people so they can kind of make the choices they want to make more easily, right?
And are you finding in your practice that, are you finding that more people are coming into these programs to seek help?
Yeah, I think we do have, fairly low barrier access in our individual clinics, but it could be better. I think, we could have a more seamless system where, even family doctors in the community aren't aware of our clinics. Family doctors who are near our clinic aren't aware of our clinics. or services related to substance use. And so really making sure that we have campaigns to educate the public about these low barrier access clinics is crucial. And we do see new people all the time. We're intaking people all the time, and we're a walk-in service, so we really try and emphasize the low barrier access, and see as many people as we can. I think one of the things as a whole system, I mean, this applies to, I would say, programs all over North America, is that the system tends to be a bit disconnected. So if someone say is in the community and they're not able to stabilize on treatment in the community at a clinic, and maybe they need to go to a detox center so they can get onto the medication there in a safe and stable environment. And then if they want to go to a treatment facility, we have bed-based treatments, 90-day programs where patients can go. The important thing is for people to move easily and quickly through the system, so they can access the care as fast as possible. And that's a big problem right now. We don't have access. People are on waiting lists for 6 to 8 weeks at a time.
Wow.
And people are dying on those wait lists. So it's an urgent issue.
A challenging situation.
It is very, So
considering everything's becoming more and more
prevalent
with all the discussions that we had about the accessibility of some of these drugs, especially with kids and
exactly.
So it is a challenge. But what about the stigma and the stereotypes that's associated with drug use and users of drugs and addictions and addicts that come in? One, from their own perspective, not being shy about talking about it, but also the society's perspective on them, stereotyping them of drug users or this or that, right?
Yeah, it's an excellent question. I mean, it's one of the it's a very long-standing issue going back maybe millennia, like where people would see others who struggled with alcohol use as they would use negative terms to associate with them, right? And they would be seen as other, or they would be othered in society, right?
That's right.
And I think there's a push now, and we need to do more in terms of trying to change the understanding of someone with a substance use disorder. It is an illness, right? And an illness deserves compassion, care. These are people in our community. All of us, we are probably, a few degrees of separation of someone who struggles with a substance use disorder, their family, their friends, right? So we need to understand that, and that they have our genetics. They are part of our families, and we need to really have that compassion and understand why they're in this place, right? One thing I think we should be, or we are changing, is the language of addiction, right? So we're using the term substance use disorder now, right? So someone with a substance use disorder, it's kind of analogous to saying someone is a diabetic, right? No one's a diabetic. It's someone has diabetes, right? So it doesn't. It's not all encompassing for their life. It's not an identifying term for them. It's someone who struggles with or who has a condition. So really looking at the language that we use and changing that language is really important to destigmatize and demystify substance use disorders.
Yeah, I think that's such a big thing in the society, because a lot of people associate drug use with just labeling people. And you often hear the sentence, "Oh, why don't they just stop using it?" And I think there's a lack of recognition that it is an illness and a disorder that you talk about, right?
Yeah, it is. And I think we we read news reports all the time, and I think that is only contributing to the underlying stigma of substance use disorders. People who do steal, right, or who commit illegal acts, and often these people are surviving. They're just trying to survive, right?
That's right.
And we need to understand that with a better, sort of more compassionate lens. Yeah.
Yeah, just kind of more education in the public to understand the mechanism and the physiology behind it, the reasons behind it, and the psychosocial pressures on some of these people and what they've gone through. At the end of it, it is an illness.
Yeah.
It is a disorder.
It is, and I think there's no one-size-fits-all approach, but there are bare minimum things we can do as a society. Yeah.
And in your perception, things are moving in a better direction in terms of education and...
I think so. We have, do you mean in terms of like having people learn about addiction?
Learn about it, understand it. And we talked about the science of it that is always improving and people having more access to it. So do you see across the whole wide range of these topics, do you see that there's improvements?
I think there are improvements. I think access to media, to the internet has really allowed people to access information better. I do think that is a positive in terms of learning about substance use disorders and what they are. And I'm still pretty young in practice, so I don't know. I haven't seen that shift because I haven't been practicing for a long time. But the people who come to me are very intelligent and they know a lot about it, and sometimes know more than me about it. And I'm humbled all the time, every day, about how much people know about it, and I'm constantly learning from people, from my patients who are living that day-to-day experience, right? So I think for the general public too, I think we could still do more. I think there's always more work to be done around it. I think there's more work to be done in our medical education, right? So we are. I have learners who come through, like medical students, residents, where they undergo an addiction medicine rotation, which it's historically never been taught in medical school, but it's slowly starting to become more and more a part of the curriculum, which is important, right? We need people to provide the care, and we need to expand that more too. Yeah.
So a lot more work to be done on the horizon, but it is improving in a steady, positive direction.
Yeah, in some ways, it's not, and we need more. I think we need more advocacy to the government as well. We need more resources and more funding for treatment. That's always going to be the case, but we still need to do more. Yeah.
Dr. Cohen, Craig, pleasure to have you on the show. Thank you so much for
it's been amazing
helping us and making us learn more about substance abuse and addiction, right? Substance abuse disorder, right?
Substance use disorder.
Substance use disorder. Thank you so much.
Thank you so much.
Thank
All
you.
right.